In this lecture, we're going to examine some of the specific CNS pharmacology concepts. For this lecture, we're going to examine the overview of neurotransmitters and their potential role in disease. We're going to look at a specific problem in terms of CNS absorption, the blood-brain barrier. We'll talk about P-glycoprotein, and we're going to examine the concept of efficacy delay and counter-adaptation. The major neurotransmitters in the brain include glutamate, GABA, dopamine, serotonin, and norepinephrine. Glutamate is primarily the excitatory neurotransmitter, and this transmitter is, of course, a drug target when you want to increase excitation, specifically in the use of a glutamate agonist, or reduce CNS excitation using a glutamate antagonist. GABA is primarily the inhibitory neurotransmitter. GABA, of course, is a drug target when you want to reduce CNS excitation. The actions of dopamine, serotonin, and norepinephrine depend on the receptor that it binds to, which is why it is placed in the regulatory group or the regulatory circle. The neurotransmitters that control mood, behavior, attention, emotion, and cognition are in this category as well. As you can imagine, a loss of these modulatory neurotransmitters can lead to alterations in mood, behavior, and cognition. For example, in depression, the low energy can be attributed to a reduction in norepinephrine and often the lack of emotion due to a lack of serotonin. Therefore, modulation of dopamine, serotonin, and/or norepinephrine pharmacologically is a quite useful treatment. Drug delivery into the CNS is a very difficult topic, and both pharmacologically and chemically, this barrier has to be overcome. So first, remember that the brain is considered a privileged organ. It is so because there's a blood-brain barrier. The barrier is controlled by tight junctions, and of course it is so tight that nothing can get in. The tightness of the barrier is achieved twofold. One, it supports cells such as astrocytes, which release factors that help support and maintain the barrier. And second, the tight junction, referring to the small gap right here by the endothelial cells, is made up of a number of proteins that tightly seal the endothelial cells lining the blood-brain barrier, thus limits the paracellular diffusion. The junction between the endothelial cells and the periphery are not as tight as they are in the brain. Therefore, in order to cross, drugs must use transcellular diffusion. In order for a drug to be able to cross the plasma membrane, it must be lipophilic due to the properties of the plasma membrane. Drugs that can cross into the CNS tend to be more lipophilic than most other drugs. A lipophilic drug, of course, will have a large volume distribution, and it will have the ability to diffuse into fat, as well as have a long half-life. And while there is a physical barrier, there is also a biomechanical barrier, and that is the activity of P-glycoprotein. P-glycoprotein is a transmembrane transporter protein that basically pumps out foreign substances. Once the drug crosses the membrane, it can bind, of course, to P-glycoprotein on the cytoplasmic side of the transporter. Once bound, it will be pumped out of the brain. If a drug can bind to P-glycoprotein, it is considered a P-glycoprotein substrate and will therefore eventually be eliminated from the brain as it is actively pumped out. There are drugs, of course, that can induce P-glycoprotein or increase the pumping of the drug and the substrate out of the brain. And there are drugs that can inhibit P-glycoprotein or reduce the removal of a drug or substrate out of the brain. So, of course, in this particular cartoon, the green drug is the substrate because you can see it being actively pumped out by the P-glycoprotein. And then this red drug is an inhibitor. And notice the inhibitor has affinity, of course, for the P-glycoprotein pump, but is not expelled by the pump. Okay. And then the third category, the inducer, is not shown here, but an inducer would be a drug that induces the expression of this protein at the genomic level. It doesn't necessarily interact with the protein at the biophysics or biochemical level. Other names for the P-glycoprotein include the ABC transporter, also known as the ATP binding cassette. It's also known as a CD marker. I think it's 250 something, CD 250 something if you're an immunologist. But because it does utilize energy, it's also called an ATP binding cassette. If this was a bacteria, it would also be known as a multiple drug resistant pump. All of those refer to the same basic protein structure that basically pumps out foreign molecules, and those foreign molecules, of course, are drugs. Another layer of complexity to think about in terms of CNS drugs is that while many of them are biologically active in the brain, they are administered orally, meaning a large percentage of the dose actually ends up going through the liver metabolism. So let's review the CYP enzymes, because actually a lot of the CNS drugs are also CYP enzyme inducers or inhibitors. So it's kind of the same story with P-glycoprotein. We've got CYP substrates. So if the drug is a substrate, basically it gets converted by the CYP enzyme to another compound. There are CYP inhibitors, which this pathway is shown here in red, and there are CYP inducers, and this pathway is depicted here in green. A CYP inducer will actually often increase the metabolism of the drug, which often reduces therapy. A CYP inhibitor, on the other hand, may decrease metabolism of the drug, increasing the risk of side effects and toxicity. Now, this scenario that I'm showing in this particular image is really depicting the biotransformation outcomes when the substrate is a prodrug, which becomes biologically converted to the active drug via the CYP enzyme. There are other examples or alternative explanations where these outcomes are different. So this is just one possible example out of potentially 5 or 6, maybe even 7 different outcomes. But I like this diagram because many of the CNS drugs are prodrugs, and they rely on CYP enzymes in the liver to convert them into a biologically active compound that is often more lipophilic and then eventually crosses the blood-brain barrier, which comes into therapeutic play. The problem is that when you co-administer these drugs with other drugs, and many of these patients are on multiple drugs, of course, if the co-administered agent happens to also be a CYP inhibitor, that means less prodrug is going to be converted into less active drug, resulting in too little therapy. If the co-administered drug is an inducer, that means the prodrug actually goes through the biotransformation process relatively quickly, leading to an excess therapy. So a 35-year-old man is being treated for depression and starts a new medication. He takes his medication as directed and complains to you about not feeling better despite having been on this drug for 2 weeks. He insists on trying a new medication. You urge him to stay on this medication as you say it takes time. He asks why. And the reason is because CNS drugs, particularly drugs that modulate serotonin and norepinephrine, have what's called efficacy delay. And it's a rather odd phenomena where, in spite of a new drug being administered and being properly dosed and properly taken, you don't actually see any clinical change in mood for 4 to 6 weeks. And this is in spite of immediate increases in neurotransmitter levels. And patients don't feel better right away. And the reason is because it takes some time for the brain to respond to the increased levels of neurotransmitter. And this is at the protein and genomic level. The brain has plasticity, of course, meaning it's dynamic, meaning it's fluid, and it's adapting to the changes in neurotransmitter. This is after several weeks, months, years of being at persistent low levels of neurotransmitter. And then that leads us to this concept of counter-adaptation. And so in terms of counter-adaptation, the brain adapts when it encounters change. It adapts by changing its structure during disease progression. There are many changes, of course, and counter-adaptation is just one of them. But during drug therapy, the changes in neurotransmitter synthesis and release and the density of the receptors, both presynaptically and postsynaptically, are dramatically altered. Thus, a removal of CNS drugs also requires adaptations. And therefore, we remind you of the central axiom to CNS drug therapy is never abruptly remove a CNS drug, as the consequences will be rather dramatic, and the neurotransmission is going to start to rely on these adaptation measures that have been kind of put in place while the patient was taking these drugs. And so a lot of the side effects in terms of abrupt withdrawal are very, very potentially life-threatening and very serious and require immediate attention. So never abruptly discontinue a centrally acting drug, especially in terms of tricyclic antidepressants or SSRIs.